We do have our quorum to start, so we're going to make a start. So I want to call the meeting to order. We are, of course, going into public session now. So I want to declare the meeting open to the public online. And can I welcome all members who are participating by video conferencing. Can I remind members about the protocols regarding the use of electronic devices? And we want to move straight to apologies. And I know we have apologies from Colin McGrath and also from Colin Gilbert, and Colin has given his vote for today to Orlea Flynn. So any other apologies from any of the rest of the members? No? Okay, thank you. So we're going to move straight to our briefing from the RQIA on the neurology reviews. Members, I want to advise that officials from RQIA are here today to update the committee on the work of the RQIA in relation to the review of deceased patients of Michael Watt and other reviews. So included in your pack is the briefing paper provided by RQIA. Also included for reference are papers from the inquiry panel, GMC and the department. So can I at this stage welcome by video link Breege Donaghy, Chief Executive of RQIA, Emer Hopkins, RQIA Interim Director of Improvement, and Dr Leanne Morgan, RQIA Clinical Lead. So if can I invite at this stage Breege if you want to brief the committee, and then we'll go into questions.
Good afternoon, Chair. Thank you for welcoming us. We'd like to thank the committee for the opportunity to provide a progress report on RQIA's work relating to neurology inquiry. As you've indicated, I'm Breege Donaghy, I'm Chief Executive of the Regulation and Quality Improvement Authority, and joined by my two colleagues that you've already introduced. To bring the committee back to the context of our work, in May 2018, RQIA was commissioned by the Department of Health to undertake three particular pieces of work. The first of these was a review of the governance of outpatient services in Belfast Health and Social Care Trust, with a particular focus on neurology and a number of other high-volume specialties as well. And the outcome of that piece of work was concluded and published around February in 2020. The second piece of work that was commissioned by the department was a review of governance arrangements in the independent or private hospitals and hospices across Northern Ireland. And that work was completed by RQIA and involved others. And the results of that and the recommendations from it were published in June 21 of earlier this year. The area we're focusing on today is the third piece of work that was commissioned by the Department of Health of us and through us, an expert review of the records of deceased patients of Dr Watt who had died during the 10-year period 2008 to 2018. And today we'll update the committee on a progress around that latter piece of work. As the committee will be aware, the extract that had been received in relation to the number of individuals who may fall into that time period identified a significant number of patients. Around 3,500 individual records were retrieved on that data set. And on that basis, RQI had agreed with the Department of Health to take a phased approach to the review. I should say that while that data set that came to RQIA from the Health and Social Care Board includes over 3,500 neurology patients who died within that period, I should emphasise that that initial extract from computer records does need to have ongoing validation carried out on it. Given the way clinics and so on are set up on computer systems in hospitals and what have you, it is possible that some patients who have been retrieved through that process may have attended appointments that Dr Watts was co-joined in terms of joint clinics, for example, perhaps with another consultant neurologist, and the patient may not actually have seen Dr Watt. Therefore, it's important just to point out that it should not be considered at this point that the deceased records referred to in that large data set are all directly linked to Dr Watt. I just want to make that point clear from the outset. However, it is still a very considerable piece of work, and a phased approach was agreed. In undertaking the work, we set about carrying out that first phase of preparatory work to create the processes and the methodology to provide a robust process. It's important, I think, to say that these processes and arrangements are all bespoke to this particular piece of work. They have been established particularly to undertake this expert review of the deceased patient records. The arrangements did not exist before, and they've included the need to develop a range of underpinning frameworks, including a legal framework to enable RQIA and ultimately the expert panel to have access to the deceased patient's records and to take receipt of these records and store them safely and so on. The records came from hospital and GP records, and they're largely paper-based. It's been important to our staff and all those involved with this process throughout the whole of the programme that we are mindful to the concerns and distress of families involved in this. And as a result, we established what we call our new family liaison team. Again, it is a bespoke response to this particular review, did not exist in advance of that. And focus now particularly on the undertaking of this particular expert review and this particular phase of it. The expert review panel has been commissioned from the Royal College of Physicians, and it includes experienced neurology consultants from outside of Northern Ireland. It is actually that particular expert review group who will conduct the detailed review of the records and are conducting the review of the records of the deceased patients. RQIA have commissioned those independent panel of experts through the Royal College. The group of records that the expert panel are reviewing are made up of the records of 45 deceased patients, and these include 29 deceased patients whose families have made contact with RQIA with their concerns about the treatment and care their relative may have received, and some of those serious concerns, and 16 patients that would otherwise have been included in the Belfast Trust's live recall of patients, but who sadly had died either before attending that recall or before their assessment or reassessment had been completed. As a result of those 45 records, we generated 70,000 individual patient pages of records, and we have supplied these in electronic form to the expert panel. In addition to that, the expert panel committed to reviewing information shared by the families of deceased patients, and the RQIA family liaison team have assisted families to record their information and evidence, so to speak, experience, and we have provided that to the expert panel, who have also agreed to review that information alongside the records from hospitals and general practice and so on. To do this work, we provided a point of contact for families, and members of that family liaison group, including Dr. Leanne Morgan, who's with me today, and other experienced clinicians and so on. These colleagues were all identified because they have skills and experience in engaging with families on what are very sensitive and personal issues. And in addition to face-to-face meetings, we provided a range of other information and emails and written documentation and so on. 23 families agreed and accepted our offer to meet with our family team face-to-face, and others have engaged through other means of email and Zoom and so on. We also made efforts to contact the next of kin of 16 patients who had died before either attending or completing their reassessment in the recall. We wrote to their GPs offering engagement, and one family did come forward and another has engaged with us through other means as well. Each of these families wished to have their concerns regarding the care and treatment provided to their relative by Dr. Watt considered by the panel, and the families have been assisted in recording their experience and their information through stories. We have finalised each of the content of these with individual families to their satisfaction, and now those are all also in the possession of the expert review panel. I just want to emphasise again, Chair and colleagues, that to enable the review of these records by the expert panel, there is a very substantial scale of work involved, despite the relatively small number of records, 45 in this first phase. The paper records scanned have created approximately 70,000 pages of records. Each of these will be read by the expert review panel. Before doing so, we have went through them and redacted any personal identifiable information, and we've quality checked the records to ensure they're legible and readable and catalogued them. The records, as I say, included records from hospitals and general practice, but it also included other clinical records, including death certificates and information that might have been available from the electronic health record that's shared across organisations in the health and social care system. Where they were available, we also would have included coronial reports and records from the independent hospitals where Dr. Watt may have seen patients. These records have all now being created into an electronic form, and we are advised and secured from the expert panel that they will provide an initial summary of their findings, both a review of those individual records and family stories, by late November this month. This summary then we intend sharing with the Department of Health, and no doubt it will inform discussions about the phases ahead. The Royal College expert team has indicated it will also then provide individual patient summary records for each of the 45 deceased patients on the review, including the family evidence provided. These reports should be available to families by April 22. And we will be careful in engaging with families about how they wish to receive and review those personal records, and will assist them in doing so. I would add, Chair, that we continue to reach out to families. Throughout this whole process, we have been mindful that it has been lengthy, continues to be so. It has been our endeavour to ensure that the process we've put in place, which is bespoke to this review, that it is robust, that it can withstand scrutiny, and that it is meaningful. We are acutely aware families are anxious to find answers, as is the wider system. They are keen to hear the findings of the expert review panel and to apply the learning from it. I would just conclude, Chair, by saying that beyond the completion of this work, which we are entirely committed to work expeditiously between now and April, as I've mentioned, we will take further direction from the Department of Health on the next steps and possible future phases. We have no doubt that the outcome from this current work will be vitally important, will influence and shape the way forward. But right now, the emphasis of it is to complete it and to commit on what we've indicated to families and others, so that we can find answers for those families who patiently have awaited and engaged in this process, and to the wider system, who this piece of work forms a very important part of the overall review of neurology services. Chair, I'm finished there in terms of the opening statement. I'm very happy now to take questions or any clarifications needed.
Thank you, Breach. That's much appreciated. I just want to kick off straight away, basically, and get into questions. I know members will have questions as well, but just to fire a few quick ones at you. Can you just clarify or explain the delay in the RQIA inquiry into deceased patients getting started? This has obviously been an incredibly traumatic ordeal for all the families that have been involved, as recently has been demonstrated in the second Spotlight programme. So if you could explain that delay, and could you tell us what stage specifically the investigation is at now, and could you give us the timescales for reporting on the work into deceased patients of the former Dr. Watt?
Yes, Chair, I've really made some short reference to it in my opening remarks, but the first thing I would like to say on behalf of myself and my colleagues, we are sorry for families who are engaged and enduring this lengthy process. It is being lengthy, as you say, and the delay, as was referred to in terms of actually starting the review of the personal records, perhaps it doesn't explain adequately the amount of preparatory work that has been required to undertake this. I did mention, Chair, in my opening remarks too, that there had been two other substantial pieces of work completed at the same time as this, or at least commissioned at the same time in May 2018. And I have no doubt that they have also taken some of the resource that might have been available otherwise to concentrate on this particular early elements. But I think it's really important to say that this is a bespoke process. There are not easy benchmarks to draw off the shelf, so to speak, to go about doing this. I think it's important to say RQIA did not hold these records. We had to secure them from the organisations that do hold them, including trusts, and through the Health and Social Care Board, records from general practice and so on, and from diagnostic systems. It's been really important to us and the team that I've met with here who've been involved all along to create a really firm, sound platform for receiving and reviewing those personal records. This is not something we addressed easily or lightly. It required us developing what we call a legal framework under data protection regulations and under the authority that RQIA has to investigate and scrutinise a service delivery and quality. It also required an ethical framework. It also required the setting up of the bespoke, unique family liaison team. And all of these things have played their part, I believe, in contributing to the lengthy period of time this process is taking. I do think, and I'm relatively new to RQIA and I've been reflecting with colleagues in these last months, there may have been opportunities earlier on in the process where perhaps we could have compromised on the processes in order to increase the pace. But we have been mindful of the importance of the work, and families want, and the whole wider system wants, accurate findings and findings that can be relied on. And we have put tremendous effort into building those arrangements to create that. But as I say, we will reflect to see if there was potential to do anything differently. But it has been, I am convinced, that it has been a direct consequence of the need to put rigour and scrutiny into the system and to make it meaningful. As I say, there was other pieces of work. COVID itself, of course, has had some impact, and there was a short period in that whole programme, a few months, where the review was paused. But overarchingly, Chair, I would say to you that that is what has caused the delay, as we refer, in terms of actually getting in to the Royal College, who've now been commissioned, independent experts from across the UK, to actually review these individual records. And I suspect that people feel that is the real start to this review. The preparatory work, doesn't particularly feature, and we understand why that would be the case. I referred in the introduction about the time frame to complete the work. The Royal College, who we've commissioned, and we're happy to share the detail of who's involved in that and so on, if that's helpful, have committed to us that they will provide that high-level review of those 45 records, substantial amount of pages and so on that have been incorporated in that, as well as the family evidence papers by the end of this month, the end of November. The plan then is to also have individual patient records available for families by April of next year. And I suspect that we will be engaged then with the Department of Health in considering the outcome of that work and the learning and the application of it, and ensuring that there's rigour applied to the implementation of those recommendations and so on. And any actions that might be necessary out of it, where the Royal College experts, for example, may identify issues that have to be reported onwards to other organisations, that would also form part of considering the recommendations from that review. I hope, Chair, maybe I've explained the reasoning behind the lengthy period of time it has taken us to build the methodology and systems to make this meaningful and robust. But I do apologise to families for the no doubt distressing time it has been for them and they've cooperated and worked with us throughout this process, and I hope that we can continue to support them. And the period of time we're looking into now is the end of this month as a key time frame for us, and then April of 22. Don't know if that answers the question entirely, Chair. Very happy for myself or colleagues to add further to that.
Okay, no, I think that's okay for now. And yes, you referred to additional detail. I don't know if you want to give that now or whether you want to supply that in writing in terms of the Royal College Commission.
Whichever members would prefer, Chair, I ask my colleague, Dr. Leanne Morgan, maybe just to refer to the membership of the expert panel, if you would, Leanne. Thank you.
So the expert panel, which has been established is chaired by Dr. Peter Belfield, who's the Medical Director of the Invited Service Reviews. The review panel comprises 3 independent neurologists from outside of Northern Ireland. That's Professor Alistair Bowles at University of Cambridge, Dr. Tabish Safi, who's a consultant neurologist at Northwick Park Hospital, Dr. Jennifer Quirk, who's a consultant neurologist at Prince Royal University Hospital, and also a lay reviewer called Ms. Sally Williams.
Great, thank you very much. Okay, I wanted to ask you as well, Brigitte, if you can clarify what role Mr. Tony Stevens has within the RQIA, and that's previously and presently. And does Mr. Stevens have any direct involvement or oversight or contribution to the RQIA investigation into the deaths of patients who the then Dr. Watt was treating. Obviously, he has had a previous managerial role in relation to Michael Watt, and there would be a significant conflict of interest if he were involved in any way in the investigation. So if you could clarify that for me.
Chair, Dr. Stevens, as you say, is a former interim chief executive of RQIA and took up the position here for a period of about 9 months, leaving at the end of June just past. And I took up the position of chief executive of RQIA from that point forward, the 1st of July. Dr. Stevens currently doesn't have any role involved with RQIA in any formal way whatsoever. And my understanding from speaking with Dr. Stevens and our chair and other colleagues who've been involved in establishing the steering group and the other subcommittees, that Dr. Stevens stood aside from any involvement in the review of deceased patient records due to that concern of any potential conflict of interest. So he had no role in the oversight or management or processes that were set up in RQA to undertake this expert review, and has no role currently.
Thank you for that clarity. Okay, it's been reported by RQIA that you've identified in excess of 3,500 deceased patients of the former Dr. Michael Watt over a 10-year period from 2008 to 2018. That would roughly equate to 1 patient death per day over that 10-year period. Would it be correct to say that this is a very high number? And would it be correct to say that you are only examining 45 cases? I think you'd already referred to that in your brief. And if that's not correct, how many are you investigating? Could you tell us what your sampling method is? And can you tell us how and why the patients that were chosen?
Chair, yes, it is correct to say we are currently reviewing the records of 45 deceased patients, and in a moment I'll ask my colleague Emer Hopkins to just take us through why those particular 45 patients were selected and so on. Just to go back to the point first about the 3,500 records, as I mentioned in the introduction, that is a data set, I can't think of another way to describe it, but an extract from the computer systems held by the health and social care system that have identified the potential where Dr. Watt may have been involved in the care and treatment of particular patients from across the system in that 10-year period. However, as I mentioned, in terms of the way systems are set up on computers across Northern Ireland, PAS systems and what have you, we cannot accept that that is a record of patients actually seen by Dr. Watt. Clinics can be often set up as co-joined or shared across clinicians, and each of those records will have to be examined to determine whether or not the patient was actually seen by Dr. Watt. So it would be, first of all, premature to say that those records actually relate to patients seen by Dr. Watt. It's an extract that would have to yet then be subject to detailed scrutiny and coding, analysis and so on to determine those that were actually seen by Dr. Watt. So I wouldn't be in a position at this point to say what proportion of those are patients who were under the direct care of Dr. Watt. But I will ask Emer Hopkins to explain how we selected these 45 patients for this first phase of the review, if that's okay, Chair. Thank you.
Breeze, sorry, Breeze, just before you go to Emer there, would you know when you'll be in a position to have a more accurate figure than that 3,500? Or is there a time scale for it?
I wouldn't be able to say at this stage because it will be subject to discussion with the Department of Health on the future phases. I mean, the Department of Health have indicated to us, have agreed with us some time back, that we should go about this in a phased way, given the scale of what is likely that we're facing into. And that's why that, although we've made some assessment of some parts of that data set, only sufficient to let us see that not all of those records for those patients were patients of Dr. Watt. We would need to discuss with the Department of Health how they wish to direct us to take forward further possible phases of this work before I could give an indication of how long it would take us to complete that review of that full data set and get to a final number, should that be what we're requested to do. So I apologise that I can't give you a time frame for that at the moment.
Thank you.
In relation to the sampling, Chair, what became apparent just very early was that our internal infrastructure would only allow us to handle and process a certain amount of records safely, bearing in mind all the necessary new confidentiality and security arrangements that needed to be built around that. We arrived at a pragmatic number that we could process at around 50, and we knew there was a lot of uncertainty around the data set, and an approach where we sought to optimise equity and sampling on the basis of postcodes or deprivation or conditions would have, in our view, taken an enormously long length of time, and we were balancing that with the pace and urgency required to commence the review. So we initially had been contacted during the initial years by 29 families. Having reviewed the content of their experience, we believed that there was very important learning within those cases, but still we knew we could review more than 29, and we were aware that a small number of patients who were due to be reviewed under the live recall processes had sadly died before that review was commenced or completed. And we thought that that was a fair and proportionate decision to include that cohort as well. And that brought us to a number that we felt that we could manage expediently and robustly and properly. And that's on the basis on which we proceeded with that. Further work has started on that data set, and that data set is a list of potential patients at the minute. And we have identified within that there are some patients who were not in fact seen by Dr. Watt. And as we move forward, the resources required for a more robust validation of that list will be part of our future planning for the work.
Okay, thank you, Emer. And I have a couple more questions, and then I'll go over to other members. And Emer, I think this might be for you. During the examination of deceased patients, are you looking specifically at any connection there might have been between Michael Watt's treatment or mistreatment of the patient and the ultimate cause of death? And if you have found a cause of death where there's a potential connection to the treatment or mistreatment of a patient by Michael Watt, will you already have reported this to the Service of Northern Ireland?
So at this stage in the process, we are not aware of the outcomes of the review because the record review has been undertaken by the Royal College of Physicians. They have been provided with death certificates. They will, as part of that, be looking at the completeness and accuracy as far as they can tell with those death certificates. And part of the recommendations that they will be making may include further actions for RQIA in terms of onward referral to other agencies such as the coroner, the PSNI or the GMC, but all of that is an unknown at this point. I hope will form part, if there is any findings to that effect, that will form part of the interim summary that we're expecting this month.
Okay, thank you. I'm just going to move to other members now. Carol?
Thank you, Chair, and thank you, panel. Rach, I'm just curious, and maybe even a bit confused. RQIA is independent of the Department for Health, okay? So you had mentioned that you were waiting on the Department for Health concluding what would be appropriate from the reference to a data set. Could you maybe expand on that? Because I'm confused why the RQI be waiting on the department rather than instructing the department. So
yes.
if you could respond to that.
Yes, of course. Important maybe to establish that under our regulations, the legislation that allows RQIA to operate, RQIA can independently undertake reviews of services based on information available to us, reports, evidence, concerns, and so on. But also the Department of Health can direct us to undertake work on their behalf as we provide an assurance to them and to the Minister and to the wider public about services that they may have concerns about or wish to have investigated. So whilst we have independence in carrying out our regulatory function, we can be commissioned by the Department of Health and directed to undertake a piece of work. And in these particular circumstances, this piece of work has been commissioned by the Department of Health for us to carry out and commission this expert review. So there is a variable, if you like, in there, in that we can be commissioned to carry out work. We can also independently undertake work based on evidence that comes to us. I would say another aspect of it, in our regulatory work, carrying out our functions of inspections and reviews and in all sorts of facilities across Northern Ireland, both statutory and independent. The independence is in the consistent delivery of the regulation and enforcement powers. They are delivered consistently, without bias or without favour. So we independently effect the authority of this RQIA body. But it doesn't mean we work in isolation. On the contrary, we depend on engaging with communities, with advocates, with providers of services to understand the challenges and issues that are going on that can direct us to undertake our work. So we're not in isolation. We are independent in effecting our authority responsibly, robustly, and without favour. But in this particular case, we have been commissioned to undertake this piece of work. So naturally, we look back to the department who commissioned the work to check what other steps they wishes to take in the months and time ahead. I hope that helps clarify.
No, it actually does help clarify it, and I'm not questioning your independence. I just questioned the matter at which the department, the reference to the department was, so that's clear for me. How many families are you aware are currently pursuing a criminal investigation through the PSNI into the treatment of their loved ones?
I'm not aware, I'm sorry that knowledge is available to me. I don't know. We do liaise with the PSNI, as Emer has said, where it's necessary in all parts of our work, but I'm not familiar with the PSNI investigation.
And so then, are you aware of any coroner's inquests in relation to the deaths of former patients of Michael Watt?
Yes, and Emer referred a moment ago, and I may ask Emer just to step in again and clarify that where we have coroner's reports available to us, we have supplied those to the expert panel. Emer, would you comment on that?
Yes, we have a regular meeting with a member of the coroner's office to keep them abreast early of any findings that would be arising as part of the review of the families that we met and we received detailed experience from. We know that a very small number of those families had previously been through a coroner's process. We understand that only whenever there is new changing evidence for the coroners to consider would they reopen any cases, and I think it would be much too early for us to presume that would happen as a result of our record review at this stage. But I don't have the exact figure. It is a very small number, but there are people within our initial 45 who have been through a coroner's process.
So that's clear, because I couldn't understand where the figure of 45 came from, the 3,500, and then I'm assuming it was a random selection of the 16 deceased patients from that group of 45. But effectively, I suppose the question I'm asking is, when the three independent or the four independent panel, investigate the records of those deceased patients, they may advise or recommend that the initial findings needed further investigation, so effectively the coroner could reopen the case. And then my last question is, so I appreciate the clarity around Dr. Tony Stevens in relation to the RQIA. Are you aware of any health and social care officials who had responsibility for the management and supervision of Michael Watt? Have they been investigated or spoken to by the RQIA in relation to this ongoing review?
Well, maybe if I take the first point and then go back to Emer again about the findings from the expert panel, Emer, and where that may go, should there be discrepancies or issues identified. But in terms of seeking to interview a range of colleagues who may have or may not have been involved in the management or oversight of Dr. Watt, what I've mentioned earlier is we have been commissioned by the Department of Health to do a very specific piece of work. It's to review the deceased patient records in that 10-year period, to commission an independent expert review panel to do so, to report the findings and to take the recommendations from there. It does not include our wider investigation of the governance arrangements of Dr. Watt in particular, supervision rearrangements or interviews with individual managers or professionals, or indeed Dr. Watt himself. That is not part of our commission. It's a very restricted, if you like, in that sense, very focused on the experience of families and the records and what they tell an independent range of experts about what has occurred here, and to report the findings on those. So it doesn't go into that broader range. There may be others part of the system who are looking at that element. I would say that I did mention earlier that we completed a very substantial piece of work on the governance of outpatient services, particularly neurology, and some of the other high-volume specialties in Belfast Trust, and we published the results and recommendations from that in February 2020. Now, whilst that doesn't go into individual clinicians, it did make recommendations around strengthening governance arrangements in outpatient services involving general practice, prescribing arrangements and so on. So there's a more general review of governance, but we're not involved in the specific interviewing of individuals responsible for oversight in that regard. And if it's okay with your good selves, I will ask Emer just to comment again on the findings or potential findings of the expert panel and where they may take us.
Yes, and I can keep it very brief. In all our work, including this review, it is, there's potential for RQIA at any time to come across individuals whose professional practice decisions or otherwise might need to be considered by their professional regulator. And RQIA only works effectively when it's working in close partnership with a whole range of professional regulators. It is conceivable that perhaps in undertaking the review there may be practice relating to other professionals from a range of disciplines that would need further consideration. And again, we have been alerted already to the possibility that that could be something that might form part of a recommendation from the Royal College. But at this time, we are fully blind, I guess, to the findings, and we remain very objective, and we remain ready to cooperate and act on any recommendations that the Royal College of Physicians panel makes to us, which could conceivably include further discussions with professional regulators.
Thank you, Chair.
Thank you. Deborah?
Thank you to the panel. Breach, I think you mentioned there during your contribution about, you talked about patients joining, or Dr. Watt joining joint appointments, and I just wanted to pick up on that. Correct me if I'm wrong. You know, there's quite a sizable amount of deceased patients there, and Dr. Watt, you know, was at joint appointments, so therefore would he not have had a say in those patients and their diagnosis, and therefore should that not be looked into as well as a result of that? Just correct me if I'm wrong on any of that, but I just wanted to pick up on that to be totally clear.
I may have misled you. What I was saying was that in the setup of clinics on the computer systems held in trusts, for example, a clinic may be set up to allow patients to be booked in to individual clinicians, to shared responsibilities across clinics and so on. But I cannot say to you that Dr. Watt was involved in shared clinics. I can only say that the computer system data that has been retrieved on our behalf has identified his name in the overall clinic setup. But that would not necessarily mean, I wouldn't want to say that I have any inside knowledge into how clinics are established, but from the computer system, it gives you a high-level insight into the clinics, but you then have to drill into each patient to see who actually saw them. So I'm not saying to you that they were joint clinics. It may only have been the setup on the computer system that allowed clinics to be held under different clinicians' names on different dates and different times, and yet his name has come out on the data set. So it's more a data cleansing approach than any indication that the clinics were jointly held. I wouldn't want to give you that impression. If I have done so, apologies for that.
No, thank you for that. Thank you for clearing that up, Breach. In June, regarding the procedures of the review of the deceased patients, the RQIA stated that on completion of the review of these records, the Royal College of Physicians will provide the RQIA with a report of their findings, highlighting any lessons to be learned, and will recommend appropriate actions. They will also provide an individual case summary for each patient reviewed, which the RQIA will use to provide feedback to those families who have expressed an interest in receiving this. Have the RCP provided the RQIA with a report of their findings on the first 45 cases? And if so, what was the outcome of that report? And if not, when is RCP report on the findings due to be published?
No, we haven't yet received that report. We expect to receive the overview of the 45 records and family evidence that was presented at the end of this month.
Okay, thank you. And in June, the RQIA stated again that the large number of deceased patients have been identified as falling within the scope of the review. You talked about the numbers there, earlier on. Will there be further efforts to encourage the families of those deceased patients to engage with the RQIA, so that they have input? And the RQIA can get a good view of what really happened, and what progress is being made regarding the optimal mechanisms, infrastructure and resources required to support a further phase mentioned by the RQIA.
Well, perhaps I could say a couple of things and maybe invite Dr. Leanne maybe to give a bit of insight into the work with families. But our family liaison team was established particularly to support this work, to provide a point of contact for families who are concerned and anxious and want to be assured and understand what the process is about. And when we encourage families to continue to come forward to us, yes, absolutely. For those families who are already affected and engaged with us, they may well have contact details for us. For those who haven't yet but would wish to come forward, we would encourage people to do so, and perhaps at the end of our session we might give the phone numbers and various things where people can contact us if they would choose to. So we definitely would encourage people to come forward, and we will do our level best to engage with them and provide support and reassurance. The scope of the review is very substantial, as you've said. We've already mentioned several times now the 3,500 records in that data set, which still needs an awful lot of work to be done to progress it. I think it's important to say that we do need to wait to have the findings from this phase, from that Royal College Overview Report, which we expect at the end of this month, and then for the individual families, those reviews will be available to them in the spring. I am certain that the outcome of that work is bound to influence and shape the next phases, and how we might approach that. And as I referred earlier, very much engaging with the Department of Health, given they've commissioned this very specific piece of work. So I can't at this stage say what the resources would be needed to carry out further phases, but I think it is fair to say that if we were repeating the scale of the exercise we've done so far, we are talking substantial resources required over probably a lengthy period of time. But it'd be premature to state what that is, given we still need to wait for the findings of this first phase, which we expect to be vitally important, not just to the individual families, but to the wider system, and definitely to shape the process ahead. If it's helpful, Dr. Leanne, who's part of our team in the family liaison group, can give a modest insight into the types of mechanisms and things we've provided for families, and onward support to counselling service and so on for people who have requested it and feel in need of it. But happy to stop there equally if you prefer to maybe move on to other questions. Very happy to take your steer on that.
I'm happy enough, Breach, if Leanne wants to come in.
Thank you very much, Member. Families have very much been at the forefront of our minds throughout this review. In our review structure, we have ensured service user representation, for example. We have established an ethical advisory group who developed an ethical framework to ensure that our engagement with families was as ethical and sensitive as possible. In the methodology that the expert reviewers are using at Royal College of Physicians, we were very keen that the family stories would be heard and taken into consideration as part of that expert review. So the family liaison team set up to facilitate the sharing of those stories and to help the families capture those key points and agree what they wanted shared with the expert review panel. That family liaison team, as my colleague Breach mentioned in her opening statement, comprises clinicians, I'm one of the members, and also clinical psychologist, which has been really, really valuable because, as you can understand, some of these families are very distressed, they are grieving, they're bereaved, and on top of that, they have concerns about the quality of care and treatment. So it has been an exceptionally difficult time for families, and it's a very difficult process to go through. So with that in mind, we have provided families who want to avail of it with access to the Inspire Wellbeing Counselling Service, and some family members have chosen to take that up and have found that valuable. We also produced written materials on the review to provide information, and also on coping with grief to help bereaved families. And we have been conducting regular liaison with families, particularly over the summer months, to agree those statements. And in the coming months, as we will be receiving the outcome of the expert review, we're very aware that this is likely to be a very stressful time for families. So we will be providing them with regular updates, with support, with a range of options by which they can engage with us to hear the outcomes of the expert review. So they can engage with us face-to-face through our family liaison team, by virtual meeting, by email, by telephone if they so wish. And we will re-offer that counselling service to families who feel it may be of benefit to them.
Thank you, Leanne.
Okay, thank you.
Okay, Alan?
Thanks very much, Chair. And thank you, Breach, and your colleagues for the information that you've supplied to us this afternoon. But I sort of sense that you really have to have a loved one who died while under the care of Dr. Watt to maybe fully appreciate the emotions and the mental suffering that they're having to deal with. You know, there must be so many questions going through their minds, and they really are depending on you and your team in this situation. Some of the people who have contacted me feel that they're perhaps been left behind in this whole scenario. And I'd just like you to maybe reassure them, Breach, that all families of deceased patients will receive a full investigation into the death of their loved one under the care of Dr. Watt, and that they will not be subject to any form of a lottery to get the answers that they crave to have. And this is a huge task that you've started a journey on, and I just wonder, do you have, or will you have the resources, and will the expert panel have the resources to fully deal with what is going to be an absolutely huge task? And what would be, and it might be an impossible question to answer, Breach, but what would be your best estimate of a timeline of getting through this process to completion?
Thank you, colleague, for that. I'll try and take a number of those. First of all, may I say that you're at the outset of your statement, for families who feel left behind, well, may I apologise to them and invite them to make contact with us, and we will do our level best to keep them engaged and supported. But it is difficult because it is asking people to wait and to tolerate this, this lengthy period of time for this review process to be complete for this first stage. So, just our heart goes out to families who are affected by this, disappointed to think that we might have let families down in some way. Please encourage people to come forward and contact us, and we do our level best to support them and involve them through what is a distressing time. There's no doubt about that. For all families who've been involved and chosen to be involved in this first stage of the family liaison service and are part of the 45 group that we mentioned, yes, the Royal College, the expert review panel, have undertaken to provide individual reports for those families, and that's due around April time. It's difficult to say at this stage. Well, first of all, in terms of resources, I should add that RQIA had resources made available to us, sufficient to allow us to undertake the work that we have during the course of this year and up to the spring of next, and sufficient to allow us to engage the expert review panel to do so as well. So when we have asked for the resource to carry out the work, the Department of Health made that funding available to us, and colleagues here then took the steps to put the staffing in place to undertake it. But the other questions you ask, I believe, take us into the territory of trying to predict the steps beyond this process. Now, as I mentioned earlier, we've been commissioned by the Department to carry out this process. It's been agreed to do that in a phased way and to produce the findings from this first cohort of 45 patients' records that are being reviewed. We believe the findings from that and how it's reported and actions and so on will be vitally important. They're important for the families immediately who are involved, but I think they're also important for the broader range of service users, families and others who've been sadly party to this whole arrangement, this whole process. The learning from this, whilst it relates to 45 individuals, might well have application far beyond that. So I think we need to be mindful that these results are important, not just for the immediate families, although vitally so, but also for wider families, wider service users in the wider system. We believe that should also be part of the consideration then in what are the steps beyond that. We've already maybe partially explained the amount of work that will be necessary or would be necessary to validate that full data set and so on. We are very happy to speak with the department after with the results of this cohort back. I can't give you a commitment to what the next steps will be. We're commissioned to provide this service. We may be commissioned to provide further phases of it. I can only assure you that we believe, made very substantial progress in establishing the methodologies and the systems that not only will benefit this inquiry, but stand us in good stead for other inquiries, of course, sadly, but also for the work that we do as a regulator. We've learned a lot about engaging with families and service users and what is needed to begin to put in place the arrangements to support and guide people through that process. I would have to say to you, it has been and is an absolute privilege for us to have this opportunity to be engaged with families at a time that is the most distressing period of their lives, and to the concerns they've had about their loved ones. And that's why our family liaison team have basically been hands elected for their skill and expertise in working through that process. We believe we've created and learned a lot that we can apply in other settings, but I can't at this stage say to the committee what the next steps or give a guarantee that every record would be explored or examined and produced in the individual detail that these first 45 will be. But equally, I can't exclude that. I don't know. We will engage with the department who have commissioned us to carry out this work and share the evidence of what we've done to prepare for it, the findings from the expert panel, and we will work with them to scale and scope what the next steps are ahead.
Well, I certainly want to thank you and your staff and the expert panel for your efforts to date, and I wish you well going forward. Thank you.
Thank you very much.
Thanks, Alan. I'm just very aware of time here, and I know Orlea is online, and she hasn't her hand.
Or Starleaf, maybe, I don't know.
Starleaf, yeah.
Oh, Starleaf.
She
yeah.
hasn't her hand raised, but I'm not sure if Orlea is looking in with anything. But maybe if you can hear me, Orlea, if you can use your raise hand function if you do want in. I suppose just to finish off, in terms of the review into independent sector, can you tell us a bit about what the RQIA are recommending about erasing the disconnect between the independent sector and the NHS? The former neurologist that's been put to me, Michael Watt, took advantage of this disconnect, and it was very difficult to get any records he kept in his possession to be seen in the future by anyone within the NHS. The independent clinics were just buildings where patients could see doctors, but if that patient then went to NHS, they had to start again with records and tests. With the huge waiting list at the moment, this disconnect surely needs to be changed. So, do you have any recommendations around that at this stage? And just to say too that, you know, it's been put to me that the RQIA reports should be about the improvement of patient care and, of course, about the safety of patients. And the experience of some patients was that the former neurologist, Michael Watt, gave NHS patients his WhatsApp number and told them to contact him directly. And while this, you know, would have seemed to have been helpful at the time, it left patients then in a very vulnerable position, meaning that when things went wrong, as they especially did after botched epidural blood patch procedures, some of which were not recorded in the patient's notes, the patients had no one to turn to. When Michael Watt did not answer his phone or when he was suspended, patients would contact their GP, who did not have any advice to give, as these instances were rare, and patients would then ring the neurology ward and ask for advice, only to be told to contact their GP, and the GP would then write for an appointment asking for an appointment to be expedited, and nothing happened. And then patients were then forced to go to Michael Watt privately to try and get help to recover from the botched blood patches. So it just seems that, you know, in all the reviews by the RQIA, once again, patients do feel that experiences in the NHS and private sector, had they been harvested when RQIA reports, could have been improved. You know, so obviously there does appear to be that disconnected. I want to know if you want to take this final moments just to make comment around that, or tell us if you are recommending something in around that disconnect between the independent sector and the NHS.
Chair, I'll just mention the two pieces of work I referred to earlier, and your question and just very firmly explains why they were also commissioned. First of those was a review of the governance arrangements in outpatient services in the Belfast Trust, but actually it's also something that's being taken forward across all trusts, and a review of governance arrangements in independent hospitals and hospices. And in the recommendations that we've made there, they do cover that need for engaging pathways between private and statutory care. They also engaged very substantially with general practice, asked their views, carried out surveys, held interviews and so on, and with service users. And there have been 26 recommendations made in the first of those reports and a further 20 in the second. So those are important reports as well, and they're the underpinning arrangements to try to improve those shortcomings in governance arrangements and connections between general practice and secondary care, patients, secondary care and primary care, independent sector and statutory sector. So there's a very comprehensive range of recommendations that relate to much of what you've described in your narrative.
Listen, thank you very much. I'm very conscious of the time, and I think our time has really come to an end, and I'm very appreciative of your time. You're undertaking very important work. So I wanted to thank you, in particular, Briege, to Emer and Leanne for your attendance at the Health Committee today, and wish you all the best with concluding in your investigations and reports. So thank you very much.
Thank you.
Chairman Committee, much appreciated.
Thank you.
Thank you. Okay, members, so that really concludes this meeting. So just on to the date, time and place of next meeting. Our next meeting is going to be held on Thursday, the 11th of November, and this will be fully virtual due to the Remembrance Service taking place in the Senate Chamber. So thank you very much, members.
Thank you.
Thank you.
This is the Northern Ireland Assembly Committee